Hello, my name is Michael Redman. I'll be teaching you for my course Delivery and Design class 10-minute presentation. I'm a driver engineer, Station 32A shift. For this topic, we have a couple things we're going to talk about. I chose for my teach back to be on patient assessment. I know that it's something that we do on a daily basis and everybody feels that they're pretty good at. It's very basic. You learn it from EMT school all the way up through medic, and throughout your career it continues. However, there are a lot of things that we miss. There are a bunch of aspects that I'm going to be discussing today on patient assessment, so we're going to get into it. Patient assessment is something that we do without even realizing it. We get on scene, we can assess the patient from the truck. If it's a trauma, car accident, something like that, we start assessing them and thinking about what we need to do. We determine their transport priority, we see if they have C-spine issues, and we can tell their level of distress for the most part from us arriving on scene. There are other aspects that we miss though, however. So as I stated, this is a patient assessment, are broken down into 6 subcategories: our scene size up, our primary assessment, our history taking, our secondary assessment, vital signs, and treatments that we may perform for these patients. Understanding that every patient is not critical and that you don't have to go into as much depth on, say, a stubbed toe that's an isolated injury, or how you may have to go into a lot more depth for a female that's pregnant and nausea and you have to rule out a bunch of stuff, or the unresponsive patient that we have to take care of. So we're going to get into it, starting with our scene size up. Everybody knows the spiel through EMT school and fire school and medic school. BSI, scene safety, number, location of patients. So breaking this down, your BSI and scene safety go together. Our body substance isolation refers to, now with COVID, our masks, our goggles, our gloves, our gowns, all that to keep ourselves safe from our patients that may have COVID or other issues that we could get from them. Scene safety is not just the officer's job. Understanding if the scene is safe, if it becomes unsafe, if there's any issues we find as a crew, we can talk about it and get out of there. Determining if the scene is safe or unsafe. If it is unsafe, understanding that you can decide to stay and shelter in place, or you guys have to get out of there. Our crew safety is number one. We are concerned about the patient, but at the same time, we have to take care of ourselves, and if we have to leave the patient where they are for the time being, we will do that. Mechanism of injury versus the nature of illness. Is this a trauma? Is this a medical? Is it a mixture of both? Was somebody in a car accident that led them to, had a heart attack causing them to be in a car accident? So doing a little investigative work just in our scene size up, as you see. Resources needed, additional resources for, say, structure fire. We're getting engines, rescues, ladders, battalions, EMS captains. If you're a rescue, 2-man rescue on scene of a chest pain, you may need additional resources. Call for that engine. If it upgrades to a cardiac arrest, call for that EMS captain. Get as many hands as you need. Get units rolling prior to needing them. If you don't need them, cancel them en route, but it's better to have them on the street than it is for them to be in bed and have to get up and help you later on. C-spine precautions is also the last thing that is thrown into the initial size up. Something that we can see from approaching the patient, as I said earlier. Is their C-spine suspected? Is it a motorcycle accident? Is it a car accident? Or is it just a back pain, non-traumatic, chronic issue? So understanding that you got to rule C-spine out and take those precautions for these patients. Our primary assessment. This is the initial assessment after the scene size up that we're getting when we get to the patient. As it says up here, we start with our introduction and we go all the way to determining our transport priority. So as we approach our patient, we want to introduce ourselves. For me, it's Driver Redman. What seems to be the issue today? How can I help you? You got to get the age, sex, and weight of your patient. Gets you rolling on, okay, if it's a 6-year-old, maybe we're going to our hand heavy. If it's a 75-year-old person, maybe we can rule out some of these other issues as we approach. Something that we want to know is the patient alert. If they're unresponsive, we're going circulation, airway, breathing. If they're responsive and talking to us, we're going ABCs. Determining if they're alert and oriented, if their GCS is 15, if they're altered, that's going to bring us down our route of investigating the issues. And then we go into our ABCs from our determining that level of consciousness. Is the airway patent? Are they breathing? What's their rate, depth, and quality? What's their pulse? Or is it rapid? Is it thready? Is it fast? Is it slow? We're determining all those things. Once we have determined their breathing, step back a second, we can also get lung sounds from them. So breathing, rate, depth, quality, get my lung sounds assessed as well. From that circulation, we're going to go to controlling bleeding. If we note any bleeding or a hemorrhage on scene, we got to work to stop that. If they're bleeding, exsanguinating, we aren't really worried about anything else because that bleeding is going to cause them to code. So if you see bleeding on that scene, stop that immediately. From the bleeding, we're going to skin color, condition, temperature. As you have your hand on the patient's chest, checking if they're breathing, you can get a skin color, condition, temperature. Are they pale, warm, cool, moist, diaphoretic? That stuff will tell you what you're thinking. If it's a chest pain and they're diaphoretic, you should be getting that going to think maybe they're possibly having a STEMI or a cardiac event. Once you get that skin color, condition, and temperature, you're going to do a 60 to 90 second rapid scan. It says that on your sheet, I understand that, but you're going to be doing that assessment as you're walking up to your patient and seeing if there's any life threats. Once you get down to this part, it's our last part of our primary assessment. You determine your transport priority. Are they a load and go, or are they a stay and play? By this point, you should know and understand what they are for the time being and how to get your patient rolling. Following that primary assessment, we're going into history taking. Your history taking includes your sample and your OPQRSTI. You're getting any history that you can from either the patient, bystanders, or family members. Sample stands for signs and symptoms, allergies, medications that the patient takes, pertinent past medical history. So if they had a stubbed toe 6 years ago, that's not really pertinent. You want to know cardiac, anything that's major to the patient's complaint at this time. Last oral intake. Last oral intake is important for if the patient's going to go to surgery, something like that, or if they're having an allergic reaction, you want to see if they ate something new and it caused that. And events leading up to. What caused the chest pain? When did they start having it? What were you doing prior to all of this coming on and exacerbating you to call 911? OPQRSTI is the last one, it's not up there. Onset. When did this start? Was it rapid, slowed? Provocation, P? Does anything make it better or worse? Quality. What's the quality of the pain? Is it sharp, achy, dull, throbby? Does it radiate? R. Does it go from your jaw down to your chest or your arm? Thinking it's cardiac related. Severity. Rate the pain for me. 0 being none, 10 being childbirth. For women is a good way to go because that'll get them thinking, okay, well, I'm having abdominal pain, but it's not like when I had my child. For men, think about broken bones, something like that. 0 being none, 10 being the worst pain you've ever felt before. And time. How long has this been going on? Did it start now? Has it been 6 months? Has it been a year and a half? And I is your interventions, which we'll get to towards the end in your treatments. But what have you done to fix this in the past? Has anything helped you? Next, we're going to go up to our secondary assessment. This is when we're doing our full head to toe, getting our hands on the patient, specifically for trauma patients. The 60 to 90 second scan is done in your primary. This is going to be your head to toe. You're starting at the head. You're inspecting and palpating everything all the way down the body. Anything you find, you're noting. Anything you can fix, you fix. You're bandaging, you're cleaning at things, and you're taking care of the patient, whatever it is. If it's a trauma patient's a naked patient. So we're going to be cutting all the clothes off that patient and taking care of them in order to make them better and getting them prepared for the trauma center that we will be going to. So something that's overlooked on your head to toe. So head, chest, equal rise and fall, abdomen, soft, non-tender, you're getting your lung sounds going down. A lot of things that are missed, people don't really go through, are the genitalia area. Priapism,